Good morning, everyone. Welcome to today's presentation. I'm Dr. Usam Hassan, and I'm excited to discuss glomerulonephritis and RPGN with you. On this first slide, we see the title of our talk, which highlights these important kidney conditions. Over the course of this session, we'll explore their causes, clinical features, diagnosis, and management. Let's get started and delve into these fascinating topics together. Let's take a closer look at this scenario. We have a 45-year-old man presenting with cola-colored urine, which suggests the presence of blood in the urine. He also has periorbital edema, indicating fluid retention around the eyes, along with hypertension and a reduced urine output. These signs point towards a significant renal issue. The urinalysis shows proteinuria at a ++ level and blood at a +++ level, which confirms that there is both protein and blood leaking into the urine. Now, when we think about nephritic syndrome, what are the key features? Typically, we see hematuria, often with red blood cell casts, hypertension, and some degree of proteinuria, usually less than in nephrotic syndrome. Looking at the options, option B, hematuria, hypertension, AKI, and mild to moderate proteinuria, best fits the presentation of a nephritic syndrome. It highlights the classic signs of inflammation in the glomeruli leading to these clinical features. So, in summary, this constellation of hematuria, hypertension, reduced urine output, and the urinalysis findings really points us toward nephritic syndrome, which is characterized by glomerular inflammation causing bleeding and reduced filtration. Recognizing these signs helps us differentiate it from other renal conditions, which may have different features. Let's look at the correct answer, which is B now, moving on to the explanation. Nephritic syndrome is primarily characterized by inflammation within the glomeruli, the tiny filtering units in the kidneys. This inflammation causes a variety of clinical features. First, hematuria, meaning blood in the urine, is a hallmark sign because the inflamed glomeruli allow red blood cells to leak into the urine. Along with that, patients often experience acute kidney injury, or AKI, which reflects a sudden decline in kidney function due to the inflammation. Hypertension, or high blood pressure, is also common because the damaged glomeruli disrupt normal kidney regulation of blood pressure. Lastly, subnephrotic proteinuria occurs, which means there's protein in the urine but not at levels seen in nephrotic syndrome. So the key takeaway here is that nephritic syndrome involves inflammation that leads to these characteristic signs: hematuria, AKI, hypertension, and moderate proteinuria, all of which connect to the overall theme of glomerular disease. All right, let's take a closer look at this question. We have a 60-year-old woman experiencing rapid decline in her kidney function over just 2 weeks. She's presenting with hematuria and proteinuria, and her creatinine has shot up from 90 to 420 micromoles per liter. These signs suggest significant glomerular damage. Now, the question is, what pathological finding defines rapidly progressive glomerulonephritis, or RPGN? When we think about RPGN, we're looking for specific histological features that indicate a severe and swift injury to the glomeruli. Among the options, mesangial hypercellularity, global glomerulosclerosis, crescent formation, amyloid deposition, and tubular necrosis. The hallmark feature of RPGN is crescent formation in the glomeruli. Crescents form as a response to severe injury in the capillary loops, leading to proliferation of cells in Bowman's space. This is a key indicator of the aggressive nature of RPGN. So, in summary, crescent formation is what defines RPGN pathology, reflecting the rapid and severe glomerular injury that leads to quick deterioration of renal function. Correct answer is C now. Let's delve into why that is. RPGN, or rapidly progressive glomerulonephritis, is characterized histologically by crescent formation. These crescents are essentially accumulations of proliferating cells in Bowman's space, which occur as a response to severe injury. The key point here is that this injury involves the glomerular capillaries, leading to damage that's so severe it results in crescent formation. This process is a hallmark of RPGN, and understanding this helps us differentiate it from other glomerular diseases. So, The main takeaway is that crescent formation indicates a severe glomerular capillary injury, which is central to the diagnosis of RPGN. This concept ties into the overall theme of how histological features reflect underlying pathophysiology in glomerular diseases. All right, let's look at this case. We have a 28-year-old man presenting with hemoptysis, which is coughing up blood, hypoxia indicating low oxygen levels, and acute kidney injury, or AKI. His urine shows red cell casts, which suggest glomerular bleeding. Plus, the anti-GBM antibodies are positive. This combination of symptoms points strongly toward Goodpasture's syndrome, which involves both the lungs and kidneys due to anti-GBM antibodies attacking those tissues. Now, when approaching treatment, the key is to rapidly control the immune response to prevent further damage. The most effective initial approach in such cases involves plasma exchange to remove circulating antibodies, combined with high-dose steroids to suppress inflammation, and cyclophosphamide to inhibit further antibody production. Looking at the options, the best initial treatment would be D. Plasma exchange plus high-dose steroids plus cyclophosphamide. This combo targets both the circulating antibodies and the immune system's overactivity, giving the patient the best chance for recovery. Remember, early and aggressive intervention is critical in these cases to prevent irreversible organ damage. This approach aligns with the overall theme of managing immune-mediated glomerulonephritis effectively. The correct answer here is D. Now, let's talk about anti-GBM disease, also known as Goodpasture syndrome. This condition requires urgent and aggressive treatment. The key components of that treatment are what's called triple therapy. First, plasma exchange, which is used to rapidly remove the harmful antibodies from the blood. This step is critical because these antibodies are attacking the kidneys and lungs. Second, immunosuppression, which involves medications to dampen the immune response and prevent further antibody production. Together, these treatments are essential to control the disease quickly and prevent irreversible damage. Understanding this approach is important because it highlights how prompt, targeted therapy can significantly impact patient outcomes in autoimmune conditions like anti-GBM disease. All right, let's look at this case. We have a 67-year-old man presenting with weight loss, hematuria, acute kidney injury, and pulmonary infiltrates. These symptoms suggest a systemic process affecting both the kidneys and lungs. Now, his ANCA is positive, which points us towards a Viskich-Letuch process, and notably, his complement levels are normal. This detail is important because it helps us narrow down the diagnosis. Among the options, the key is to recognize that positive ANCA with normal complement levels is characteristic of certain types of vasculitis, specifically NCA-associated vasculitis. This condition often involves small vessels, leading to issues like glomerulonephritis and pulmonary hemorrhage or infiltrates. So, considering all these points, the most likely diagnosis here is NCA-associated vasculitis. This case underscores the importance of integrating clinical features with laboratory findings to arrive at the right diagnosis in complex systemic diseases. All right, let's discuss the correct answer here, which is C when we look at NCA-associated RPGN, or rapidly progressive glomerulonephritis. It typically causes a pauci-immune pattern on biopsy. That means there's minimal or no immune deposits seen under the microscope. This form often presents with what we call pulmonary renal syndrome, where both the lungs and kidneys are involved, leading to symptoms like hemoptysis and rapidly worsening kidney function. An important point to remember is that in these cases, complement levels are usually normal. That's a key feature because, unlike other types of glomerulonephritis where complement levels might be low, here they tend to stay within normal limits. So, to connect this back to our overall theme, understanding the immune mechanisms and clinical features helps us differentiate NCA-associated RPGN from other glomerular diseases, guiding us toward the correct diagnosis and management. All right, let's take a look at this question. We have a patient presenting with nephritic syndrome, which typically involves hematuria, hypertension, and some degree of reduced kidney function. Now, the labs show low C3 levels but normal C4 levels. This pattern is quite important because it helps us narrow down the possible causes. In conditions where we see low C3 but normal C4, it often indicates activation of the alternative complement pathway. This is a key clue because different glomerulonephritids activate different parts of the complement system. Now, looking at the options, the most consistent condition with this lab pattern is post-streptococcal glomerulonephritis. It usually presents after a streptococcal infection and is characterized by low C3 due to complement consumption, but C4 remains normal because the classical pathway isn't primarily involved. In contrast, diseases like Yensier-associated vasculitis or anti-GBM disease typically don't show this complement pattern. Similarly, diabetic nephropathy and minimal change disease usually don't involve complement consumption at all. So, connecting this back to our overall theme, recognizing this complement pattern is crucial for differentiating types of glomerulonephritis. It helps us pinpoint the specific pathology and guides appropriate management. And in this case, the most consistent answer is C, post-streptococcal GN. All right, let's look at the correct answer here, which is option C. The key point to remember is that low complement levels, especially C3, are indicative of immune complex glomerulonephritis. This is a type of kidney inflammation caused by immune complexes depositing in the glomeruli. Classic examples include post-infectious glomerulonephritis, which often follows infections like streptococcal infections. So, when you see decreased complement levels, particularly C3, it suggests that immune complexes are actively involved, and this points us toward diagnoses like post-infectious GN. This concept connects to our overall understanding of how immune mechanisms can lead to different patterns of kidney injury. All right, let's consider this scenario. We have a patient presenting with acute kidney injury, or AKI, along with both hematuria and proteinuria. Their renal function is worsening rapidly, which is quite concerning. Now, when do we need to perform a renal biopsy most urgently in this context? The key here is recognizing that rapid deterioration suggests an aggressive underlying process. Conditions like rapidly progressive glomerulonephritis or vasculitis could be at play, and timely diagnosis is crucial for effective intervention. In this case, the most urgent situation for a biopsy would be when there's rapidly progressive renal failure with active urine sediment, which includes red blood cell casts and significant hematuria, indicating ongoing inflammation or damage. This urgency is vital because early diagnosis can significantly influence treatment decisions and potentially save kidney function. It's important to connect this back to our overall theme. Understanding the different causes of kidney injury and knowing when immediate action, like a biopsy, is warranted to optimize patient outcomes. The correct answer here is A, and I want to emphasize why that's so important. When we're dealing with suspected rapidly progressive glomerulonephritis, or RPGN, time is of the essence. An urgent kidney biopsy is crucial because it helps us identify the underlying cause, which is often treatable. By obtaining a biopsy promptly, we can determine the specific pathology involved and start targeted immunosuppressive therapy without delay. This approach can significantly improve patient outcomes and prevent irreversible kidney damage. So the key takeaway is that in suspected RPGN cases, a swift biopsy is necessary to guide immediate treatment decisions. This step aligns with our overall goal of early intervention to preserve kidney function and optimize patient care. All right, let's look at this important question. We have a patient with rapidly progressive glomerulonephritis, or RPGN, who's now presenting with pulmonary hemorrhage and acute kidney injury. These are serious, life-threatening symptoms, and they point towards a need for immediate action. Now, the question is, what should be our first step in management? Option A suggests starting an ACE inhibitor, but that's typically more appropriate for chronic management of certain kidney conditions, not an emergency situation like this. Option B is to delay treatment until biopsy results are available, but in this case, delaying could be dangerous because the patient is actively bleeding and rapidly deteriorating. Option C involves referring for a renal transplant, which is definitely important in chronic ESRD, but not an immediate emergency. Option D recommends oral diuretics, which may help with fluid overload, but won't address the underlying severe inflammation or bleeding here. The most critical step in managing this patient right now is to initiate high-dose IV corticosteroids, which is option E. These help suppress the immune response quickly, control inflammation, and stabilize the patient. This is essential before any definitive diagnosis, like biopsy, because we need to control the immune-mediated damage immediately. So the key takeaway here is that in cases of RPGN with pulmonary hemorrhage, prompt immunosuppressive therapy is crucial. It highlights the importance of recognizing severe presentations early and acting swiftly to prevent further organ damage. This step connects to our overall theme of managing rapidly progressing renal diseases with systemic involvement, emphasizing that time is of the essence. The correct answer here is E in cases of life-threatening RPGN, or rapidly progressive glomerulonephritis. It's crucial to act quickly. Usually, high-dose steroids are started immediately, often even before biopsy results are available. The main goal is to limit irreversible kidney damage as early as possible. This approach underscores how urgent and aggressive treatment needs to be in these critical situations to preserve kidney function and improve outcomes. It's a key concept that ties into the overall theme of managing severe renal conditions promptly and effectively. Let's take a closer look at this case. So, we have a 30-year-old man who develops hematuria, that's blood in the urine, within just 24 hours of an upper respiratory tract infection. It's important to note that his renal function remains normal at this point. Now, what does this tell us? Well, the rapid onset of hematuria following an infection suggests a glomerular cause, often related to immune responses triggered by infections. Now, among the options, we're asked to identify the most likely diagnosis. Think about the characteristics: a quick onset of hematuria after an infection, with normal kidney function. This points us toward a condition where the immune system reacts rapidly and causes bleeding in the glomeruli, the tiny filtering units in the kidney. In this context, nephropathy, also known as Buddha's disease, fits best. It's characterized by the deposition of immunoglobulin A in the glomeruli, often presenting with hematuria that occurs within days of an infection, especially in the upper respiratory tract. This timing is quite distinctive. So, in summary, the key points here are rapid hematuria after an infection, preserved kidney function, and immune-mediated glomerular damage. All these clues point us toward nephropathy as the most likely diagnosis in this scenario. Let's take a closer look at the correct answer, which is C. The key point here is synpharyngitic hematuria, meaning blood in the urine that occurs at the same time as an infection. This is actually a hallmark feature of IgA nephropathy. When patients experience a sore throat or respiratory infection, they often notice blood in their urine concurrently. This connection between infection and hematuria helps us differentiate IgA nephropathy from other glomerular diseases. Recognizing this pattern is crucial for diagnosis and management. So, in the context of our overall discussion, understanding this characteristic helps us identify IgA nephropathy early, especially in patients presenting with hematuria following an infection. Let's take a closer look at glomerulonephritis. This condition causes inflammation within the glomeruli, which are the tiny filtering units in the kidneys. When these filters become inflamed, it can lead to blood in the urine, known as hematuria, and increased protein in the urine, called proteinuria. Additionally, this inflammation can impair kidney function, sometimes leading to acute kidney injury, or AKI. Now, within this category, there's a particularly severe form called rapidly progressive glomerulonephritis, or RPGN. This is a nephrological emergency because it results in a rapid decline in kidney function. If not diagnosed and treated promptly, RPGN can cause permanent kidney damage very quickly. Understanding these conditions is crucial because they highlight how inflammation in the kidneys can have serious consequences. Recognizing the signs early allows for more effective management and potentially prevents irreversible damage. So, connecting this to our overall theme, it underscores the importance of prompt diagnosis and intervention in renal inflammatory diseases. Let's take a closer look at some key clinical syndromes we encounter with glomerulonephritis. First, there's the nephritic syndrome, which is characterized by hematuria, meaning blood in the urine, along with hypertension and often acute kidney injury, or AKI. These features reflect active inflammation damaging the glomeruli and causing leakage of red blood cells. Next, we have RPGN, or rapidly progressive glomerulonephritis. This is a more aggressive form where you see a rapid rise in creatinine levels, indicating quick loss of kidney function. On biopsy, you'd typically find crescents. These are cellular proliferations in Bowman's space, signifying severe glomerular injury. Both glomerulonephritis and RPGN involve immune-mediated damage, but RPGN tends to be more fulminant. Recognizing these syndromes early is crucial because they can progress rapidly to renal failure if not treated promptly. This slide highlights the importance of understanding these clinical patterns as part of the broader spectrum of glomerular diseases we've been discussing. Now, let's take a closer look at the major categories of RPGN. First, we have anti-GBM disease, which is characterized by pulmonary hemorrhage and the presence of linear Ig-G deposits along the basement membrane. This is a pretty distinctive pattern and important to recognize. Next, there's Yensier-associated vasculitis, which tends to be pauci-immune, meaning there's little to no immune deposition visible, and the complement levels are typically normal. This type often involves small vessel inflammation, affecting multiple organs. Then, we have immune complex glomerulonephritis, where we see low complement levels, as seen in conditions like lupus or post-infectious glomerulonephritis. These immune complexes activate complement pathways, leading to more inflammation. Finally, these categories highlight the diverse mechanisms behind glomerulonephritis and RPGN, emphasizing the importance of understanding their distinct features for accurate diagnosis and management. Recognizing these patterns helps us tailor treatment approaches effectively and understand the underlying pathology better. Let's talk about investigations now. When we're evaluating potential glomerulonephritis or rapidly progressive glomerulonephritis, or RPGN, we start with urine analysis. The key thing to look for here is RBC casts, which can indicate bleeding within the renal tubules caused by glomerular injury. In addition to urine, blood tests are crucial. We typically check for ANCA, which are antineutrophil cytoplasmic antibodies, anti-GBM antibodies, and complement levels. These markers help us identify specific types of autoimmune processes that might be damaging the kidneys. However, the most definitive way to diagnose what's going on is through a renal biopsy. This gives us a direct look at the tissue, allowing us to see the extent and type of damage, which is essential for guiding treatment. To tie it all together, recognizing these investigations is vital because they help us pinpoint whether we're dealing with glomerulonephritis or RPGN. Early and accurate diagnosis is key to managing these conditions effectively and preventing progression to kidney failure. Let's talk about management principles for these conditions. First, early recognition is absolutely crucial. The sooner we identify the problem, the better the outcome for the patient. Once recognized, urgent administration of steroids is often necessary to reduce inflammation quickly. In some cases, we add cyclophosphamide or rituximab to suppress the immune response more effectively. For anti-GBM disease, especially when severe pulmonary hemorrhage occurs, plasma exchange becomes a key part of treatment. It helps remove harmful antibodies from the blood. If kidney function is severely impacted, dialysis support may be needed to maintain fluid and electrolyte balance. Finally, it's important to remember that glomerulonephritis and rapidly progressive glomerulonephritis, or RPGN, require prompt and aggressive management. Overall, Timely intervention and a tailored approach are essential to improve patient outcomes in these serious conditions. Let's go over some key pearls for MRCP Part 2 when it comes to glomerulonephritis and RPGN. First, if you see a rapid rise in creatinine along with hematuria, think of RPGN. That's a medical emergency until proven otherwise. It's important to recognize that the presence of crescents on a biopsy indicates severity of the disease, but it doesn't tell you the specific diagnosis. Next, when you see normal complement levels, consider GNCA-associated vasculitis as a likely cause. Conversely, low complement levels point towards immune complex glomerulonephritis. And finally, if a patient presents with both pulmonary hemorrhage and acute kidney injury, you should think about anti-GBM disease or GNCA-associated vasculitis, as these often involve both the lungs and kidneys. Understanding these nuances helps us tailor our diagnosis and management strategies effectively, keeping the overall goal of timely intervention at the forefront. Thank you so much for your attention and engagement today. I really appreciate you taking the time to be here. As we wrap up, I want to emphasize how important it is to remember the key points we've discussed. Whether it's about the strategies, insights, or the overall approach, each piece plays a vital role in achieving our goals. I hope this presentation has provided you with not just information, but also inspiration to move forward confidently. Once again, thank you for being part of this session, and I look forward to seeing how you apply what you've learned.